Good afternoon, everyone, and thank you again for joining us for the COVID-19 in Children seminar series. My name is Roshni Matthew. I'm an infectious disease physician. I co-chair this with Dr. Alan Schroeder. And today we have a very interesting session on COVID-19 in adolescents and mental health consequences of being away from out of school. And the upcoming sessions for the next 2 weeks, we have COVID-19 in the developing world next week. And following that, we have a session on telehealth and clinical informatics. This slide also shows you the text code that you can, for claiming the CME. Today's session is going to be moderated by Dr. Juvvadi. She is one of our the seminar series committee members. She's also the lead physician at Juvvadi Pediatrics, a part of Stanford Children's Health in Mountain View. She will take it over from here. Thank you, Dr. Juvvadi.
Thank you, Roshni. I appreciate it. Hi, everybody. Thank you so much for joining us today. During the pandemic, the COVID-19 pandemic, even though our pediatric population has not been affected quite as devastatingly as the adult population as far as COVID, we've been facing our own challenges, but no group has been struggling more to cope with this than our adolescent population. So we thought we would have a discussion today about some of these unique challenges that the patient population is facing. We have 3 amazing Stanford faculty doctors that will be discussing today some of the specifics of adolescent care during the pandemic. We will have about 10 minutes at the end of the discussion for speakers to answer questions. So please submit them in the chat box as the speakers are continuing, so we won't stop between the speakers. So our first speaker is Dr. Rachel Goldstein. Dr. Goldstein is Assistant Clinical Professor of Adolescent Medicine. Her interests are specifically reproductive health and eating disorders, and her research focus has been on improving reproductive health and informatics as it relates to adolescent confidentiality. So today, Dr. Goldstein will be talking about how the COVID pandemic has specifically impacted reproductive health care in our adolescent population. Dr. Goldstein, you can get started.
All right. So hopefully everybody can hear me. As Dr. Juvvadi said, we have our kind of 3 aims for this talk. So I'll be talking about the sort of impact of COVID-19 on adolescent care, and specifically calling out reproductive health care. Jen will talk about eating disorders, and then we'll finish up with sort of mental health piece with Jack. And you can go to the next slide. So we just wanted to start off with a case that I think kind of hit on all the topics actually all together. And this, some details have been changed, but overall sort of true case. So the 17-year-old female with depression, also has anorexia nervosa restricting type, and presented to clinic for dysuria. It was her first visit after returning home from her first semester away at college, and she was actually able to go, and luckily her school kind of figured out their COVID plan. And even though she's there for dysuria, you glance at on the weight on the chart, and she's down actually 20 pounds from when you last saw her before she left for college. And then she's she's currently sexually active with male partners only, and is in a long-term relationship, monogamous, or so she thought really. And then you test her urine, and it's positive for chlamydia. So lots of things coming up in this situation. I think one of them was just sort of, highlighting the issues that we've seen with eating disorders, which again, Jen will talk about a little bit. This patient I didn't also mention, had a flare of her mood symptoms, which we've been seeing a lot of as well. And then I think the thing, and I'll kind of hit on most, is that, these are still teenagers. So yes, they're dealing with all the other things that COVID has brought, but they still are teenagers who want to hang out with their friends and, are dating and doing other things. And so they're still at risk for the same kind of consequences of risky health behaviors as they were before. And so, I think in terms of the piece, of just adolescent healthcare in general, obviously at the beginning of the pandemic, in terms of, well checks and things like that, many institutions around the country, including us, put a pause on that. And we're really only seeing folks for acute visits. I think we quickly shifted towards having folks do telehealth, for the sort of urgent needs, and even for well checks, because we felt like, often teens are coming in just for that if they're overall healthy, and that's sort of the one time of the year that they're getting to check in about these other risk behaviors that are going on and doing a HEDS assessment. And so luckily, because we had actually been working on through other projects our telehealth for our eating disorder population, we were able to kind of scale that up pretty quickly to manage primary care and sort of other issues that we were seeing patients for consults, reproductive health care included, as part of that. And so, Jen and I actually ended up writing a paper early in COVID about kind of just how do you take care of teens and the confidential issues especially. And so, I think some of the things that we were kind of especially calling out was just making sure that the visit is set up just as well as you can in that telehealth space. So, seeing ideally parent patient together, and explaining sort of the same outlines of the visit. You'll both be seen together, and then we'll have the parents step away. And then I think especially, key in telehealth, because you can't ensure that that kid is there alone. We would ensure that have them do a sweep of their room, for instance, with their phone camera to make sure that it's really just you and them, asking them to put on headphones to, again, just add that other level of confidentiality. We had kids going to the car, going to the garage, going to the bathroom, again, just to kind of make it a safer space. And I will say our experience is that teens accepted that just fine. We have been able to essentially, do HEDS assessments just like we would in person, remotely, and kind of still follow up on all these issues. I think related to that, and not just for adolescent medicine, but other organizations, ACOG, et cetera, really highlighted the importance of continuing to provide reproductive health care in the setting of COVID. Again, people are still engaging in some of these behaviors. And so, it's important that they're protected. So I think some things to note is pretty quickly, Family Pact, which we are really lucky in California, is the insurance through Medi-Cal that covers reproductive health for people of all childbearing ages. So, we use it a lot in adolescents, but it really is, used for adults as well, basically anyone who needs confidential care and or cannot afford it. And they pretty quickly accepted telehealth as a way to provide care. And so that's been really nice. You can actually, in the before times, you had to have teens sign a piece of paper to consent. Providers are now able to sort of sign on their behalf. And then you can send them their little green card that they get to receive care in other ways, either mailing or having them come to clinic and just picking it up. But really, we've been able to provide initial consults to see, what birth control someone might want. We tend to, if someone's having symptoms, still try to get them in, but, some organizations have even said, you can do sort of presumptive treatment and an evaluation via telehealth that way as well. But that, I think, has also provided, a nice barrier. There's also been a kind of promotion of sub-Q depot as a way to allow people to give depot at home to themselves and not require them to come to clinic. And so that's really a nice option. It's something that existed before, but just wasn't utilized as much. And then we definitely still have patients coming to clinic for LARC, IUDs, implants, and really have tried to have essentially no barriers. I don't think we're really providing that care any different than we were pre-pandemic. So yeah, I think it's been interesting, but I think still very doable. I think it just kind of takes being thoughtful about, limiting inpatient or in-person visits and kind of trying to do as much as you can via telehealth to get patients that same care.
Rachel,
this
is Anita. So one of the questions that comes up often is, oral birth control pills, like how these kids can pick up prescriptions. Planned Parenthood used to be an option, and a lot of the places are closed now. So is it best to call the PCP or call you or get a consult? What would be a secure way for them to go pick up these prescriptions? Yeah.
So if it's truly confidential care that's being required, like that teen needs, so they can go on the Family Pact website and just put in their zip code and see. So obviously Planned Parenthood is probably the thing that most comes to mind for many teens. But for instance, our clinic is a site as well. And so those other clinic sites will also pop up on that list through Family Pact website. And then, as part of that guidance through Family Pact, for instance, blood pressure measurement is another thing that in normal times one would require before starting OCPs. But there really has been this thought that, if someone is a healthy person with, no evidence of high blood pressures on the last, couple of years that you have visit info on, maybe the risk benefit is such that you prescribe them a couple months, at least to start, and have them come in, a couple months later for that in-person blood pressure, or, having them do a home blood pressure if they have the machine. So again, I think as we're hopefully coming out of the increased caseload and going back into the lower risk tiers, I think we can sort of practice more like we used to, but I think there's definitely ways to think a little bit more creatively about ensuring the access. So logistically, yeah, if a patient, needed birth control confidentially, they could just call our clinic, for instance, and, no parental consent required, and they can just make a telehealth appointment, and at least we could do the consult to see what it is they need. We are able to dispense meds from clinic. That's one of the benefits of being a Family Pact site. So we can actually give the pills in hand to the kid, give them emergency contraception in hand, and then as well, give a paper prescription if needed, if that was also something they needed.
Thank you very much.
No problem.
So I believe our next speaker is Dr. Jennifer Carlson. Dr. Carlson is clinical professor of adolescent medicine, and she is involved with both outpatient and inpatient care of eating disorders. Her research focus has been on eating disorders, the female athlete triad, and adolescent confidentiality. And today, Dr. Carlson will be talking about how the COVID-19 pandemic has affected presentation of patients with eating disorders specifically.
Thanks so much for having us. And I think we could spend a whole hour talking about the management of patients with eating disorders during COVID particularly. So I wanted to try to focus a little bit more on some of the trends that we have been seeing as opposed to necessarily the medical management piece. And I think Dr. Juvvadi in a previous seminar within this series had actually talked about the surge and that we are seeing with patients and eating disorders. And this is definitely in our institution and surrounding area, but this is a national and international trend, and kind of have been framing it as a COVID-related surge in eating disorder patients. There's probably a few reasons for this. And, with any type of stress, people have their coping techniques, some of which are maybe more helpful, some which are less helpful. A lot of times I think coping techniques really do revolve around food, whether that's under eating or overeating. But if somebody is already struggling with an eating disorder or starting to struggle with an eating disorder, I think those kind of eating behaviors can just become much more exacerbated. And we're definitely seeing that. I also have had multiple patients state that with virtual learning, strangely, or maybe not so strangely, they're just so aware of their appearance because they're constantly on Zoom. They're constantly seeing themselves. So for anybody who's having more heightened kind of body image concerns or appearance concerns, they're just constantly seeing their reflection. And this has been very triggering for a lot of our patients. And then as one of my interests is athletes, and I think a lot of us see a lot of athletes in our eating disorder clinics. A lot of athletes are very, very worried about maintaining their fitness as sports are getting canceled and practices are getting postponed. We've had a lot of athletes come up with their own training regimens that are often way more intense than what would be done in a coach sponsored or a coach supervised practice. I think also just because there's often way more unstructured time because of, people aren't doing all their extracurricular activities. People also have a lot more time to work out. And so we're seeing athletes who are doing double days like every day. And if they're not able or not willing to really kind of meet those energy demands by increasing their calories appropriately, we're seeing athletes who are having weight loss, and sometimes really significant weight loss that results in more medical instability. So I think those are some of the things that we're seeing in terms of kind of increased numbers as well. But when I was thinking about just our inpatient, outpatient settings and kind of some really unique things, there are a few buckets that sort of jumped out. And I think one is that kind of related again to the stressors and everyone just having a more challenging time in general, is that we have just been seeing more and more patients getting back into contact with our clinic, having had a relapse in their eating behavior. So these are our patients who often have recovered, have been discharged from our clinic, and now they're coming back. Just again, as their stress and anxiety has increased, I think a lot of their eating behaviors have also returned, often quite surprising to kind of everybody involved. So we're seeing not just new patients presenting, but patients who previously had really been recovered. And while we always expect some people to relapse, I'm not sure we're used to seeing this rate of relapse, which has been kind of notable. I think one of the other factors that's really been driving increased numbers in our clinics is that, one of the main treatment modalities is really therapy for patients who are struggling with eating disorders. But right now, therapy is so hard to get into because the resources are just completely burdened. I think the resources were already really stretched prior to the pandemic. Mental health, I think, has never had quite enough slots for what we would like to see, but especially with the pandemic now and just having so many people struggling with different aspects of mental health, I think our colleagues are just full. And so a lot of our patients who we would typically be referring to therapy are not able to get in, even those who have private insurance. And so then are kind of left working with their medical or their clinician to kind of get things moving along, but without having that therapy support, which I think can be so critical for really recovery. And that also goes towards those who have maybe been struggling longer time and are needing a higher level of care. So the outpatient and intensive outpatient programs, the day treatment programs, the residential level of care. We have, many patients who are trying to get into that higher level of care and are being told there's a 4-month wait list. So as people are trying to get in, they're basically bouncing back and forth between their primary care physician and the hospital, because these are often some of the more medically fragile patients. And it's just incredibly challenging. I think families are challenged by it, patients, providers who are really trying to provide as much support as possible, but really can't do the structure that some of these patients may be needing. And those of us who work on our inpatient unit definitely have seen patients readmitted 4, 5, 6 times in the past few months as they're awaiting placement at kind of a residential treatment center, just waiting for a bed to open up. And again, I think this is what we are seeing nationally as well. And then one of the kind of final things, which I think we have been noting on our inpatient unit, is that patients are coming in and are just much, much sicker than what we would typically see. And patients are coming in at incredibly low weights with really impressive lab abnormalities, really impressive low heart rates. And I think it's just reflecting that people are often not getting into care or having a delay of care because, just concern about sheltering in place, not wanting to risk exposure of going and seeing their provider. And so sometimes they're just presenting at a much later stage. I think also a lot of the referrals that sometimes occur are being made by teachers or coaches or friends or counselors. And without that in-person, just in-person networking, I think some of those referrals aren't happening, so that when our adolescents are finally getting into care, they're much further along in the progression of their eating disorder, which is resulting in more frequent hospitalizations and hospitalizations that are lasting just a longer amount of time because people are presenting at such kind of a more medically unstable position. So those are just a few reflections patients that, we've noted over the past several months. The numbers do not seem to be going down by any means. And definitely will be happy to kind of talk about things as we get a little bit into kind of question and answer session and things like that. So thank you.
Thank you, Jen. Before the talk, a couple of my colleagues have asked me to check in with you while we're waiting to get these patients, plugged in with you. Is there any place that you particularly prefer that we reach out to first, or is there somewhere you would ask families to, hey, why don't you talk to, is there any place that you prefer?
Yeah, I mean, that's an excellent question. I do think, the therapy piece is so incredibly important. And I do feel like that is the one that is really lacking any space whatsoever. I think there's a lot of dietitians who are wonderful. And sometimes that dietary counseling can be very helpful, especially depending on where people are in their trajectory of their eating disorder. Right. And sometimes early on, that kind of nutrition intervention can actually make a really big difference. We do sometimes encourage, families to explore some of the resources. There's books out there about doing family-based treatment, and that can be helpful for parents who might already have that intuition to kind of help support them in doing that while they're awaiting a more formal therapy, program. But there's just not a lot of resources right now. Yeah.
Yeah. Thank you, Jen.
Thank you.
We will get to all the questions at the end of the talk, so thank you for putting them in the Q&A. Our next speaker is Dr. Jack Turban. Dr. Turban is the fellow of Child and Adolescent Psychiatry. His research interest particularly is mental health in transgender youth, but today he will be talking about how COVID-19 and the physical distancing has impacted adolescent mental health. Thank you, Jack.
Thank you. And thank you, Dr. Carlson. I'm glad we opened with eating disorders, because this has really been like a somewhat surprising and huge problem during the pandemic. I actually was just getting emails because one of the patients in the IOP that we have just became medically unstable with orthostatic tachycardia. So we'll be trying to get him connected with care, which, as you're saying, has been really tough. But I am going to try and take a little bit of time to talk about every mental health condition other than eating disorders that have also been impacted by the pandemic. So just in terms of disclosures, I received textbook royalties from Springer Nature. I'm on the scientific advisory board of Panorama Global. That's a charitable fund by Melinda Gates to support adolescent mental health during the pandemic. I've received expert witness payments from the ACLU and Coley LLP. I have a pilot research award from the American Academy of Child and Adolescent Psychiatry and their pharmaceutical partners, including Arbor and Pfizer, and have received freelance payments from various news outlets. So we don't have a ton of data actually about how the pandemic has impacted mental health, despite what the news will tell you, right? So we've had a ton of headlines, especially a lot of inflammatory headlines about suicide rates going up. It's been really politicized. So there's been a lot of talk that we need to kind of stop physical distancing recommendations due to mental health. So I want to start just by saying that we don't actually have data that completed suicides are higher during the pandemic. Part of that is we just don't have all of the data collected. And I also want to urge caution when thinking about these topics, because people have often thought of it as kind of all or nothing, that we either need to have no more physical distancing to improve mental health, or we need to have physical distancing with no social contact to kind of preserve infectious disease public health. But I want to point out that there is a middle ground where we can maintain physical distancing while not necessarily having social distancing. So this is a big thing that's been lost, that we can maintain the social connection with kids to preserve their mental health while still making sure we're thinking about infectious disease concerns. So the one good study that we do have is this report that came from the CDC that looked at the proportion of mental health related emergency room visits since the beginning of the pandemic. And what you can see is that the proportion of ED visits that were for mental health went up substantially, particularly around week 15 of the pandemic, and has stayed pretty steadily high. You'll see this statistic cited a lot, that this proportion of ED visits for mental health crises has gone up. But it's important to remember that the absolute number of emergency room visits for mental health actually hasn't increased quite that much, because there's been a relative decrease in emergency room visits for medical concerns, particularly less acute medical concerns. So if you're in the emergency room, it probably does look like there's a ton more visits for mental health, and there is a slightly increased amount, but part of that is due to a decrease in medical visits. So that increased proportion has largely been driven by adolescents. So if you look here, younger children, it's about the same frequency that they are presenting for mental health concerns in the emergency room. And a big driver of this is really adolescents, so around that 12 to 17 range. And so I'll go through the data again that we do have for a few different conditions. I think clinically what most people have noticed is that major depressive episodes have become more common and worse. There have been a few studies from China and a few in Europe, I think in Spain and Italy, where they didn't have great comparisons, but they did see that there were really high rates of screening positive for depression during the pandemic. In this review in the Journal of the American Academy of Child and Adolescent Psychiatry, looked at all of the literature that we have just about the impact of social isolation and loneliness on mental health. So again, this isn't data from the pandemic per se, but it's a similar theme of past studies where kids were socially isolated. I think the most interesting thing to take out of this is that social isolation and loneliness increase the risk of depression, but not only during that period of isolation, right? So right now we're having a lot of that isolation. We're definitely seeing kids who are telling us that they haven't been able to connect with their friends, they're feeling really lonely and hopeless, and their depression is getting worse. But this review also found that that kind of index episode of loneliness is associated with depression up to 9 years later. So one thing we'll have to think about going forward is, as kids are going back to school and having more social connection, it's possible that having gone through this period of isolation during a developmentally kind of critical period could have lasting impacts. So just something to have on our radar going forward. Anxiety has been really interesting during the pandemic. And it's important to remember that there are a lot of different kinds of anxiety disorders. And some have gotten worse, but some have actually gotten better in some interesting ways. So kids with generalized anxiety disorder, and not exactly an anxiety disorder, but OCD, those kids have gotten worse, especially kids with contamination symptoms of OCD. It's probably not surprising that they feel that their obsessions are being confirmed, that everything is contaminated and dangerous. But one interesting phenomenon has been with social anxiety. So a lot of kids with social anxiety are actually doing awesome, right? Because they don't have to go to school. They don't have to be in these social situations that get them really anxious. So in the short term, those kids are doing well. But one thing to keep in mind is that we generally think of 3 types of symptoms in anxiety disorders. So there's the physiologic symptoms of tachycardia and shortness of breath in a social situation. Those are better right now because the situations aren't there. There's the anxious thoughts and cognitions. So the catastrophizing that if I go talk to this person who's not my friend yet, they're going to reject me and everyone's going to hate me, right? But the third category of symptoms that's usually the most impairing actually are the behavioral avoidance symptoms, right? So this is when a kid is so socially anxious that they don't go to school and then they're held back for a year or something like that. And that's what's happening right now for a lot of these socially anxious kids. So we are, in a way that as psychiatrists, we would always get yelled at for, are feeding into their avoidance, right? We're telling them they don't have to go to school. They can do everything on Zoom. And so they're losing all their habituation to those social situations. and making it so that when they are re-exposed to them, when they go back to school, their social anxiety is going to be really, really intense. So one thing that we're trying to do with socially anxious kids now is find ways to make sure we're not feeding into the avoidance too much. So some of my patients, I have them like asking more questions in class in a way that they wouldn't, or maybe trying to FaceTime with other kids from school, just because we don't want them to avoid so much that there's going to be a really substantial decompensation in their anxiety when they go back to school. Another topic that I think we don't talk about enough is sexual exploitation online. So this is a piece that I wrote for Scientific American back in April. And I think we pay attention to how there's been an increase in sexual exploitation in the home. That's definitely happened during the pandemic. And I think we do a decent job counseling families and screening for that. But this online sexual exploitation is much more dangerous and often goes undetected, dangerous in that way. So both Europol and the FBI have released reports saying that online networks of sexual predators have had more activity recently. So they're aware that kids are at home, they're online more, they're not as supervised, and they're expecting that there's going to be more victimization of young people. And we've started seeing this on the inpatient units, that there are patients who subsequently have PTSD or kind of attachment style interpersonal symptoms from that kind of exploitation. So if you're interested in how to talk to kids and families about this risk and how to minimize the risk, this article has some tips. Also, kind of in my area of interest, LGBT youth, their mental health has been really impacted by the pandemic. And in particular, kind of transitional age youth have been impacted. And what we've been hearing the most is that a lot of these kids, it even happens in the Bay Area, unfortunately, they might be in families that they don't think will accept them for being gay, lesbian, bisexual, transgender, gender nonconforming. So they're closeted until they go to college. And then in college, for the first time, they can come out of the closet. They can have friends who support and affirm them for those identities. They might have a mental health provider who they're comfortable talking to about these things for the first time. But then when college is closed, all of those kids got sent back home and lost these affirming supportive networks that were having really positive impact on their mental health. And so the Trevor Project's LGBT mental health crisis line saw their volume double at the beginning of the pandemic in terms of LGBT kids being in mental health crises. So if there are any kids like this in your practice, one thing we've been recommending is if there are people from that affirming network that they can form some connection with, whether it's like a weekly phone call, just to have some affirming messages that might help buffer them against some of that internalized homophobia or internalized transphobia that they're getting from their environment, that can go a long way in kind of building resilience. So those were kind of my big pearls.
Thank you, Jack. That was fantastic. Thank you. We do have some questions that are cropping up. So I thought I would start with Rachel. Rachel, one of the questions that people had was if the adolescent is unable to come in to get the IUD replaced at the end of 5 years, what is the time frame that you are allowing them to go before they need the IUD replaced, because they're nervous about coming into clinics?
Yeah, so that's a great question. So the Family Pact website and many of us who have been providing this care for a while, even pre-pandemic, have sort of been aware of the fact that there's evidence base for many methods, not just IUD, that show effectiveness beyond what FDA approval is for. So for instance, the Mirena IUD, which most people are probably familiar with, and then Liletta is sort of the exact similar IUD. It just was developed by nonprofit and researchers to kind of compete with Mirena, but both the Libre and Adjustral IUDs. And there's evidence that they are effective up until 7 years. But for instance, Mirena is only FDA approved for 5. Liletta is now approved for 6. And again, Liletta developed really to kind of push that effectiveness. And so they, I think, will kind of continue to go back to FDA for reapproval. But I think that is like where a clinician can say, okay, yes, it's FDA approved for X amount of time, but we do have this data that shows, it's effective for longer. Obviously, it's kind of a risk-benefit decision with that patient to make, that informed decision, but there definitely is evidence. Similarly, Nexplanon is technically FDA approved, or the hormonal implant for 3 years, but there is effectiveness out for 5. So not as much of a hard line for removal based on the evidence that we do have.
A little buffer there. That's great.
Mm-hmm.
Thank you, Dr. Goldstein. Thank you.
Mm-hmm.
Dr. Carlson, a couple of questions for you. One of the listeners wanted to know, is there a 4-month wait for inpatient care, or did you mean outpatient visits?
So the 4-month is what we've sometimes been hearing for more day treatment programs, residential level of programs. However, just earlier this week, when I got what our wait was for our outpatient clinic and for a new intake, which is a comprehensive kind of full day intake, I think the wait is 6 to 7 months right now in terms of just how many people are scheduled. So, yeah.
Yes, absolutely. And I have, we have all experienced that, the pain of waiting, I know.
And I think what is really challenging is that part of the issue is that we don't have space to accommodate follow-ups. So if we could do an intake, but then we can't do any follow-up, I think that also lends to a lot of frustration from families. So we're trying to balance doing the intake, getting these kids in with being able to also meet expectations and from families about ongoing care. And I'm sorry, I wish there was a better solution, but it is challenging right now. Yeah.
Thank you. Thank you. And the ones that have gotten in and have had that all-day comprehensive evaluation are so thankful. They have nothing but amazing things to say about your team. So we do appreciate that.
Thank you.
One of the listeners wanted to know about national numbers of eating disorder trends. Do you have an idea of what the national trend is?
So I don't think I can give you a specific number. I will say, I think there's been there's overall an increase in outpatient visits, inpatient visits. I think most inpatient clinical programs have seen a huge uptick in their admission rates, kind of again, across the country. And there's many of our institutions are often talking about sort of best practices and how people are managing and trying to just kind of share sort of learned knowledge over the past few months.
Thank you. Jack, Dr. Turban, one of the pediatricians wanted to know, when a child presents with gender identity concerns, but they're nervous about going in to be seen in person, do you have any resources for pediatricians, and where would you refer them to find this information?
So in terms of mental health treatment, there's an organization in the Bay Area called Mind the Gap. That's a network of mental health providers who are comfortable treating kids who have gender diversity or have gender identity questions. So that's a good first step. And often patients need to have that care set up to ultimately be eligible for medical interventions. But if the question's more about medical interventions, I would just reach out to one of the local clinics early, so Stanford or UCSF, to get on their wait list. But I would reach out to try and get a therapist at the same time, because they're going to have to work closely together.
Another question for you, Dr. Turban, was when teens are anxious about their parents or their grandparents dying from COVID, or are just nervous about transmission, do you have any advice for these kids to return back to school? What are best practices? Do you even trust these adolescents to, keep their masks on and to be safe? So again, the question about social distancing versus physical distancing. So any words of wisdom there?
So I can't speak as much to kind of the infectious disease concerns, definitely not my area of expertise, but I would say the way that we manage this kind of generalized anxiety or some of these more specific phobias is working with kids around kind of like weighing the pros and cons of different decisions in different situations. It's a lot of cognitive behavioral therapy for the most part. It gets really tough in this area. This comes up in anxiety around climate concerns also, that these kids have a lot of kind of reasonable fears at the same time that they may also be catastrophizing and having different thinking traps that we can target with CBT. So it's a little bit of a challenge in that way, but generally you can still apply all the same principles of cognitive behavioral therapy and kind of figure out what thinking traps the kids are tending towards. So are they catastrophizing in a way that really is out of proportion to what like the data suggest and things like that. Another thing is, I think providers have to do a little bit of extra work educating themselves about what the risk is, so that whenever they're going through that CBT with the kid's not like running circles around them where they know more facts. So you kind of have to know the facts to be able to do it. But at the end of the day, I think it's a lot of the same strategies that we've used for anxiety broadly.
Thank you. Dr. Carlson, another question for you. What do you think about, just the sedentary lifestyle causing weight gain and the family ridiculing the child for this and bullying the child? Do you have any advice that pediatricians can use in their office?
Right. I will say, I think this is also kind of a pre-pandemic issue with a lot of focus on weight and kind of fat shaming, weight shaming, shape shaming people. Definitely more exacerbated is probably there's just more access to food and sometimes less exercise right now with the pandemic. I tend to just try to stay away from comments and encourage families like, this is not about being a certain weight. It's not about being a certain size, about looking a certain way. It's about kind of health. And I really try to talk about there are no bad foods. It's all about eating in moderation, eating the rainbow. I don't want you to not have any sweets because then you're more likely to binge on sweets if you finally get them. It's okay to have sweets, but you just need to have everything else as well. And then really trying to focus on activity, not to lose weight, not to be fit, but really for mood and for managing stress and finding some type of activity that you enjoy and that isn't a thing you have to do. So really trying to shift that emphasis away from like, oh, you're gaining too much weight or you're, whatever your eating behaviors are, to let's talk about the positive aspects of what you could be doing. And I would say that's generally been my advice in those situations, but I do think it can be very challenging, especially when I think a lot of us have been taught we really need to be worried about obesity and getting at getting at those higher weights. But I think really trying to targeting the more positive behaviors that are not necessarily weight related, but health related can sometimes be helpful.
Yeah, and I think in my own practice, I've noticed, the moms talking about their own weight challenges and constantly bringing that up. Like, I don't want you to be like me. Look at me, I gained some weight. I don't want you to sit like mom. I need you to sit up straight. So there's a lot of focus on the physical aspect.
Yeah, and I also think just also the comparison of a teenager to a parent. We also just say, you know what, like, I am grown. I am not, I have no more growth going on. My needs are so different than my teen's needs. Yeah. And like it's not even worthwhile comparing. Like we really need to look at each individual for what they need for their age and their growth and their activity level. And it's going to be really different.
Exactly. Thank you so much. Yeah, that was all the questions that were posted on our chat box. Dr. Schroeder or Dr. Matthew, did you have any comments or any questions that you wanted us to discuss?
Oh, there was just one other, first of all, thank you guys. That was really, really good and brought up so many important issues. There was one other question that came through, I think the chat that didn't make its way to the Q&A. And it was just asking if there are some good online resources that Dr. Carlson might recommend for eating disorders for, it seems like right now, a lot of pediatricians are probably doing the work that you guys would normally be doing because you're just too full and too busy. So how can we get the general pediatricians to be experts?
Yeah. No, I mean, it's challenging. And I know even on our inpatient unit, a lot of our hospital colleagues have been sort of taking care of patients who would typically be admitted to our unit, but there's no room. So I definitely acknowledge that people are sometimes doing care that is slightly outside their wheelhouse, and we so appreciate kind of partnering on that. From the family perspective, in terms of, resources that can be done online, there are a lot. The national, there's the Anita has a great website and it has some basic information. There is also the EDRC, which is the Eating Disorder Recovery Center for Silicon Valley, that has more local resources and some information. Again, the availability of those resources, though, just is limited right now. There are some online treatment modalities that are happening. And I think what I've been hearing from a lot of patients is that there's a new center called Equip that has online therapy, nutrition, that some patients have been looking into. Although I would say probably most providers are really doing online presence for their therapy, for even their nutrition counseling. I think for providers who are trying to kind of get up to speed, just know that we are available, and we take phone calls all the time from providers who are just asking us like, hey, what would you do in this situation? And we're kind of happy to do this. One of us is always on call. And we have been fielding definitely more phone calls from providers just to kind of help them as they're trying to triage some of their patients in the outpatient setting. So we're also very available for that.
And I thought I would maybe just try to circle back to this, what has been really a tension throughout the entire pandemic, which is controlling the virus versus managing all of these sort of secondary consequences of virtual school and social isolation. And that maybe we could start by, Raji, there were a couple questions about that always come up about transmission and what we know about transmission. And so maybe we can start by you just kind of reviewing that. And we have tried to emphasize almost every week during this session that the data has been quite encouraging. And so Dr. Matthew can talk about that. But the follow-up then for all of you would be, how can we really turn this into advocacy in terms of people that are making the policy decisions? And you may have seen yesterday or the day before, the California chapter of the AAP actually put out a letter representing all of the constituents, really emphasizing the importance of getting back to school. But how can we really serve as advocates to make sure that the people that are making these decisions are aware of the morbidities that you guys are seeing? So maybe Raji, but before you guys jump into that, Rodney, do you want to just review the transmission data again?
In fact, I did a school session yesterday, so it's fresh in my mind. Prior to like a month ago, we had information from other countries like England and Australia, where they did have schools open, and we did know that the transmission within school is actually quite low. But the good news is that we have information within the United States. So we have a publication by MMWR on Wisconsin. About 18 schools in Wisconsin that was open. And then thereafter, we have a study from Mississippi. Again, I think an MMWR that looked at children with COVID and where they got COVID from. So if they were in school versus from community. And then most recently in Pediatrics, there is a publication from North Carolina that also looked at a large population. This is K to 12, so it includes older children as well. And all of these studies have the same information, that the outbreaks within school initiated by children is actually very, very low. The North Carolina one is very interesting because they had, I want to say about 90,000 children or so I might be mixing up the numbers between the three studies, but they basically found 700 positives, but these were all from the community, and there were about 34 positives from the school, but there were no child to staff transmission throughout this entire time. So I think we are getting more and more information, and these in Wisconsin, Mississippi, and North Carolina, the schools were open during a time when there was a lot of community transmission. So it was not a time when they had low rates in the community. So even during those times, it's just interesting because they actually showed that the number of positives were actually linked to social gatherings like birthday parties or other social gatherings, and actually being in school was protective to the child. So that was also interesting. So I think we're getting more and more information on how less of an issue school in itself is for transmission.
Yeah, so that, I mean, and you know, for one thing, for that question about the teens who are worried about spreading COVID, which you absolutely do not want to dismiss those concerns, and it's a noble concern. But I mean, I hope we can arm people with what seems to really consistently be very encouraging data about the safety of schools for kids, as long as the recommendations are followed. But what about the other end of that? Doctors Goldstein and Carlson and Turban, in terms of you know, getting this information to the people about the harms of all of this, to the people that are making this.
So it's awesome that we're at Stanford because we have a huge program for kind of medical humanities and communication. So one thing that I've worked on a lot is op-ed writing. So I worked with a few psychiatrists to write a piece for the New York Times about hydroxychloroquine in the pandemic. We wrote a piece in The Hill recently about how the Biden coronavirus task force needs more mental health experts on it. But we have a ton of resources here. If you're interested and have important things to say, to connect with media outlets to get that information out there. Pegasus is the big group at Stanford.
Yeah, I will put in the chat the AAP letter, the link to the AAP letter that I think I've circulated to people within our school district, and I certainly encourage others to do as well. Dr. Bram entered a question, Rajni, about specifically about risk to teachers. To what extent were teachers included in those studies?
Yeah, I was trying to find the PMID for the North Carolina paper. That paper specifically found no risk to staff from the children. And even prior to that, when there have been outbreaks, many a time it's actually the staff that brought in the infection into the school from the community. So the risk from children to staff remains very, very low overall in all of the publications. But the one from North Carolina is still a preprint in Pediatrics.
And then, yeah, I was going to say, Dr. Juvvadi, there's another question that came in.
Yeah.
Question from Dr. Wright.
Yeah, so Jack, I think this would be a good one for you. How do we advocate for further mental health services for children in California? And what resources do you recommend for teens?
I do so much like yell at people like is the answer. But kind of like two main avenues that I think about that are productive is like, one, if you have specific information that you feel like is not getting out there in a broad way, and you feel like constituents aren't harassing their representatives enough about a certain topic, then kind of writing an op-ed that reaches a lot of people, particularly local op-eds. So writing like for a San Francisco paper or a Bay Area paper, where enough people would get fired up that maybe they'll start to put enough pressure on that resources are reallocated to mental health. The other thing is to kind of contact your representatives directly. Or if there's a bill that's coming up that you think is an important reallocation of funds, you can go testify for those things. It's kind of a constant battle. I mostly do this in the realm of like transgender mental health, but I think this is a space where there maybe hasn't been as much advocacy from pediatric providers as there maybe would be space for.
And do you have any resources for teenagers if they want to educate themselves about anxiety and depression? Or is there a site that you would recommend they get plugged into? Anything that would, give them some support?
So usually kind of the first thing we recommend is that they try to find a provider. That was almost impossible before the pandemic, so now it's even more impossible. But we'll tell parents you can go to the Psychology Today website and type in your insurance and your zip code, and it'll give you a list of providers in the area who take your insurance. The other strategy is to call your insurance company and ask them for a list of providers. However, they're notorious for giving you a list of providers who don't have availability or don't actually take that insurance. Sometimes the numbers are for like McDonald's locations or jewelry stores. So don't be surprised when families come back and the list was not helpful. But you can kind of put pressure on those insurance companies, because at the end of the day, it is their responsibility to have people in network to provide care. There has been kind of a shift towards trying to have more kind of protocolized, evidence-based treatment for anxiety and depression online, like cognitive behavioral therapy programs online in particular. But I don't know how many of them have really been ready for prime time, but that's something that I would probably also ask the insurance company. That I think some of them, not many, might have contracted with some of those companies, that they might be able to get you access to those kind of telehealth services, or even an online module that's supervised by a therapist. For the most part, it's more been trying to fight for people to get actual providers. And then we'll tell them to do things like Headspace for mindfulness, or the Calm app, and all of those things are nice for helping a little bit, but none of it's really sufficient usually for really targeting clinically significant anxiety or depression where you really want a therapist.
Thank you guys so much.
Thank you.
Thank you.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.